So you're live.
Ladies and gentlemen, we're live. We do broadcast throughout the internet and various radio sources. And we've been getting a tremendous feedback besides the people being here. I'm Ray Rocha, and we're at the Atlantis at our monthly meeting. Without further ado, I'm going to have Susan Hill introduce our speaker, which is outstanding.
Thank you so much, Ray, and ladies and gentlemen of the Republican Men's Club. It is such an honor to be here today to represent the School of Medicine and to introduce my boss and the Dean of the University of Nevada School of Medicine and Vice President of Health Sciences. He is also a professor of family medicine. He still is in there with the students and teaching classes. He is a wonderful asset to our community. Dr. L.Schwenk went to undergraduate and got his undergraduate education at University of Michigan, and he completed his residency in family medicine at the University of Utah. And I suspect that's where he first fell in love with the outdoors in the mountains of the West. And after practicing and having a very successful practice in Park City, Utah, he returned to University of Michigan School of Medicine and was a tremendous leader there for 25 years. He headed up the university's family medicine program. He came to Northern Nevada 4 years ago. He's just celebrating his 4th anniversary. You are celebrating, right? 4th anniversary next month at the University of Nevada School of Medicine. Since he's been with us at the School of Medicine, he has done quite a bit of reorganization. He's made our organization both larger and more efficient. And now we're on the brink of some great growth, and he will talk about that today, about the past, the present, and mostly the future of medical education in Nevada. L.Schwenk.
Is that working? Yeah. Not much compared to that. How's this working? Not much. And then I'll stand back. Good afternoon. Good to see all of you. Ray, thank you very much for the invitation, Gary Martin as well, and to Susan for a very lovely introduction. It is a pleasure to be here, and I am indeed celebrating. It's almost 4 years. It's been very intense, very turbulent in certain regards, very rewarding, very political, very exposed, a larger-than-life experience. And it's what's happened over the past 4 years that sort of brings us to this point, and what I want to tell you about where we're headed into the future. Can we have the slide? What I want to talk about is medical education in general, where we've come from, where we're headed, some of the political issues that are taking place, how we got here, and why we need to move on. A lot has happened in the last 4 years. Even more is going to happen in the next several years. In about 11 days, we'll find out what the legislature decides about funding public medical education in Nevada. Much of that focuses on the new School of Medicine in Las Vegas, but there's an equal and critical component that has to do with how we build out a full medical school in Reno. So I want to address a number of questions, answer those questions, provide some probably provocative information for you to think about. Thanks. So here's the first question. Why is the U.S. healthcare system such a mess? Next. How is the healthcare system going to change to address some of its current problems? Next. And what do these changes mean for Reno? I think that most people believe that Reno's always had a medical school. UNR's always had a medical school. In certain regards, we've had half a medical school because of this split between Reno and Las Vegas. Most clinical teaching taking place in Las Vegas. Students back and forth, incredibly stressful and burdensome to the medical students. Has harmed our recruitment in certain regards. Some students who will not come here because of the split. So I'm going to answer this question about what happens when we actually have a medical school, a full school, we have clinical teaching, we have hospital relationships, we have affiliation agreements. How does that affect what this looks like in Reno? And then next. And what do these changes mean for you? And how does that affect you and your businesses? And what happens to the quality of life, the quality of business life? How all of this wraps up to be part of what's happening in Reno. Next. So the medical school looks like this. A little over 1,700 faculty and staff members, a little over 700 students and residents. Next. Total budget's about $160 million. 19% of that comes from the state. So when you read about much of the legislative discussion about state funding for medical education, you hear numbers like 30 million, 25 million, 35 million. That, in the long run, is a very small piece of the total medical education budget. We earn the other 130 million ourselves through clinical practice, through research grants, through hospital contracts, through philanthropy. So in a certain regard, public medical education's got about a 4-to-1 return on investment in the sense of what the state puts in and what we earn in return. And the economic impact is huge. So I mentioned that because I want you to have a sense of scale, kind of a sense of scope. What kind of operation is this? And what sort of operation is going forward to address some of the questions that I just posed. Next. So let's talk a little bit at kind of a global level, talk about what's going on in the country, talk a little bit about healthcare in general, and talk about some of the politics of healthcare, and then sort of step that down and bring it down to Nevada, then bring it down to Reno, and then bring it down to you. The basic issue that's going on here has to do with the reform of healthcare insurance versus the reform of healthcare delivery. The ACA has relatively little to do with the delivery of healthcare. It has a lot to do with the insurance of healthcare, how insurance is provided, and how people are brought into the system. I don't want to talk about the ACA. It's important. It has influence. People have very polarized opinions about it. In the minds of many of us, it's somewhat irrelevant to much larger issues that are taking place in terms of how healthcare is actually delivered. So what's going on there doesn't have much to do with legislation, doesn't have to do with Supreme Court decisions, doesn't have to do with who's president. It has to do with economics, which I'm assuming is a topic that you might find interesting. Next. So, cost of healthcare has increased on average about 2.1 percentage points over inflation over the past 30 years. Albert Einstein said that the most powerful force in the universe is compound interest. And when you compound this, you get this. Next. We used to spend 5% of GDP on healthcare in the 1960s. Now we spend 19%, and it's continuing up. The rate of growth, interestingly, is actually moderated to a considerable extent since healthcare reform has come along. Maybe because of it, maybe not. But for the moment, there's a bit of a plateau, but some differential effects on different people and different employers. But it's probably a temporary phenomenon. This is an inexorable increase. And it's predicted that this could go to 20, 22, 24, 26, could be 30% of the GDP by 2030. It could continue on from there. Next. So in 1960, we spent about $1,000 per person for healthcare in 2010 dollars, $1,000 in 2010 dollars in 1960. We now spend $8,000 per person per year for healthcare. The actual number in 1960, interestingly, was $149 per person. That's what we spent on healthcare per person. Now we spend $8,000. Next. This is a graph. You don't need to see the axes. All you need to know is that on the bottom are years going back to 1970. Along the side is growth in healthcare expenditures. The lines across the bottom are other countries: Canada, United Kingdom, Austria, other Western countries. The line at the top is the United States. It's going up and up and up. It's sort of, you can see back in the 70s that all countries were sort of spending about the same amount of healthcare. And then in the late 1970s, early 1980s, it really started to diverge and the US took off. Next. Another version of this, you see several countries: US, Germany, UK, Sweden, Spain, and you see per capita healthcare costs by age. This is a different graph that shows age across the bottom, healthcare spending across the top, and you can see that at about age 60, the curve just takes off, no end in sight, and look at the numbers. All other countries are spending sort of $10,000 per person per year in the 80s and 90s. We're headed up towards 40 or 45,000 per person per year. Next. This is where the concepts get more difficult. The countries down the middle, you don't have to read those. It's just all the developed countries, mostly Western countries, mostly Europe and other developed countries. On the left side is quality. So there are sort of global quality measures by which you can rank countries. And you see that these countries are ranked. Top scores on the left side, sort of diminishing. The US is highlighted. You can see we're somewhere about 20th or so in terms of overall quality of our healthcare system. On the right side is cost. And look at how we stand out in terms of cost relative to the other countries. It all sort of line up kind of in the same place. The US scores more poorly than almost all developed countries in just about every measure of healthcare. It can be crude measures like life expectancy. It can be more detailed measures like quality of care for diabetes or quality of care for mental health problems, or newborn mortality and morbidity, or the delivery of various preventive services like how many people get mammograms and how many people get their flu shots. Doesn't really matter. Any measure, and if you roll them all up, the US performs very poorly. Now, when I say this, people almost always object and say, but I hear and I read and I've experienced that we have the best healthcare in the world. I say, yes, we do have the best healthcare in certain circumstances. Some truly divine, miraculous events take place, and some of you may have experienced those. We have one of the worst systems. So yes, occasional episodic care, occasional interactions, from time to time, amazing things happen. As a system, it performs extremely poorly. So in terms of chronic disease management, service delivery, mental health care, a whole host of measures, we actually do quite poorly. Then some people say, well, that's because of socioeconomic issues, and this is sort of clustered in poor populations with lower educational levels, or people who either don't have insurance or don't access health care or don't know how to take care of themselves. And that's not true. These figures apply across the board. High socioeconomic status, low socioeconomic status, doesn't matter. Our system ranks very poorly. And there's huge impact of this economically. So this affects workers' compensation, this affects disability costs, this affects the employer costs for healthcare. This affects individual bankruptcy. The most common cause of bankruptcy in the country is healthcare costs. It has a host of economic implications. And whether you think it's a moral issue or a common good issue or a social good issue or a political issue, whatever you think about those issues, it's clearly an economic issue. This is an extremely expensive, inefficient, unproductive system. And you as employers and you as business people would not tolerate this in any other part of your supply chain or your expense base. Any other part of your expense you would not tolerate this sort of performance and this kind of uncertainty. Next. Just a final piece to lay on here. So again, you don't need to see exactly what this says, but across the bottom is cost. Up the side is rankings of quality, and the top ranked qualities at the top, poorest quality at the bottom. These dots are states, and this concerns Medicare specifically. So this is how states perform, state by state, in Medicare, quality and cost. And what you see, given that the top-ranked programs are at the top of the left-hand side, the greatest cost is at the right side of the lower axis. Basically, what it says is the more we spend on healthcare and under Medicare, the lower the quality. That's what this basically says. Now, you can disagree with how we draw the line. That is statistically accurate. But at the very least, you would say there's no relationship between cost and quality. And that is absolutely certain. So there's just a pile of evidence that says we have to do better. Next. So the question is, how did we get here? And the basic answer is we have a 1950s system, kind of a post-war system with 2015 technology. So we're trying to deliver incredibly expensive, incredibly powerful, incredibly complicated science under kind of a mom and pop, one by one individual sort of system that has essentially no controls. In the old days, everybody got a little of something. You got a little injury, a little illness, doctor came to your house, did a little this, did a little that. I have a black bag. I got it from my family doctor who made house calls. I don't use it much, although I have from time to time. In the old days, the reason that doctors made house calls is that we could do so little, you might as well do it at someone's home as to do it at the hospital, because there wasn't that much to do. So the system kind of perked along, and then science and technology explodes, and you have an aging of the population. You have this massive influx of unbelievable technology that a doctor can write with just a little illegible signature. Despite the regulations and despite the what the doctors complain about in terms of burdensome regulations and oversight, we still have extraordinary freedom to order what we want and to do what we want with very little oversight. And the system is so complicated that sometimes we just do things that maybe aren't the best. So it's been said frequently, a line like this: if restaurants were like healthcare, they would have an a la carte menu without prices. But it wouldn't matter because the chef would tell you what to eat. He couldn't tell you how much it cost, and the guy behind you was paying the bill. And that pretty much sums up where we are. We have an insured system in which employers pay huge amounts of the bill, the government pays the rest. There's not a lot of incentive for patients to think critically about whether all of this technology is good for them. We have a huge bias towards more is better. And that leads to lots of difficulties because more is clearly not better. More leads to complications, more leads to things being done that you might wish we hadn't done. So we have ourselves in a system that's just really unsustainable. Next. Here's one of the problems. There's not a symmetrical distribution of healthcare delivered to the public. It's highly skewed towards a very small part of the population that is the most sick. So if healthcare was kind of distributed broadly across the population, everybody kind of had an equal stake in this, you might get some greater consensus around what would be the right thing to do. But that's not the way it's distributed. 1% of the population consumes 22% of the medical care. So 1% of the population is a huge consumer of the medical care resources. Next. 5% consumes 50%. So half of the entire system, half of everything that goes on in healthcare goes to just 1/20th of the population. So you've got a huge population of patients who consume no healthcare whatsoever. The problem, of course, is you that to the other group, and that's what insurance is all about. But again, separate from the political perspectives on this, you just got a very skewed system in which you got some part of the population that has huge investment in how this technology is administered. You got a huge part of the system who has no investment in how the technology is administered and doesn't want to pay for it. So we've got this asymmetry that causes some huge problems. In general, the political system doesn't lend itself to come together around some consensus around what would be the right thing to do. Americans in general are distrustful of government solutions to social problems. There's this great heterogeneity of the population, all kinds of different groups that have all kinds of different needs and opinions. The notion of healthcare as a free enterprise, free market system competes with healthcare as a social good, that everybody should have access to this. I don't want to get into any of that. What I want to get into is the economics. This is an economic issue. This country is harmed economically. You as employers are harmed economically because the system is not good. Next. So where are we going with this? I've answered that. Go on. Another one. Sorry. Thank you. So here's where we're going with this. The issue is value versus volume. The entire system now is driven by volume. We get paid for doing more. Hospitals get paid for doing more. There are various types of bundling, various types of capitation, various kinds of restrictions, but it's still a volume-driven system. And doctors and healthcare professionals and hospitals get paid for doing more. And we're really good at doing more. And we can really pile up the costs because we're really good at understanding how to make this system work. The system has to shift to value. It has to shift to an assessment of what do we do that actually leads to good outcomes. I can do a surgical procedure and I can say I did this surgical procedure right. There were no complications. The patient lived. That's all fine. But how did it contribute to the patient's life? How are they better for it 30 days from now, 6 months from now, a year from now? Do they live longer? Do they have a higher quality of life? Are they better able to take care of their roles? Those are the kinds of questions that we have to ask. Next. Right now, 30% of what we spend in the country, roughly $1 trillion or close to it, $750 billion per year, is wasted or dangerous or wrong. 30%, $750 billion per year. It adds up to $495 per family, not per year, but per month. So that's roughly $6,000 that used to go into wages and now goes into healthcare that is clearly, by any measure, not right, not good, not helpful, not productive, does not lead to good outcomes. And as I've said before, you as employers would never tolerate this. If you knew that 30% of what you were spending for a supplier or some expense was wasted or wrong, you wouldn't put up with that. But we do that in healthcare because it's so complicated. It's so hard to measure quality. It's so hard to measure value. Next. So we need to have new definitions of quality. The current definition of quality goes something like this. Any care that I want, anytime I want, as much as I want, from anyone I want, anywhere I want. That's how we measure quality now. That's how people view healthcare as a commodity that they have total control over and they can have as much as they want, anytime they want, anywhere they want. And that's, to some extent, what has driven us to this system. Next. We have to have a different definition, which has to do with value added. What input, technology, physician's care, medication, home care, nursing care, what input leads to some improvement in function and quality, better roles, better mental health, better able to care for your children, better able to go to work, better able to fulfill your roles at work. We have to have some discussion like that. So the quality has to have more to do with access that's appropriate, access to the right providers, not just any random access to any random emergency room, but to the right nurse practitioners or the right PAs or the right primary care physician or the right specialty physician or the right radiologic procedure or the right hospital. Lower cost and quality that's actually measured. And that's where most of the work is going on right now. How do we actually measure what we do Not did we do the procedure correctly, but what did it do for the patient's life? Next. So that gets to the R word, and the R stands for rationing. And this is the topic that always comes up, and I'm happy to take it head on. Most of us who work in this field are absolutely convinced that if we have the time to explain to patients the pros and cons of procedures and tests, the choices that patients have about different approaches to their very complex illnesses, get the right consultants, the right experts involved to give the right input, kind of structure the care, or organized care, get paid as a primary care physician and a family doctor, get paid to actually spend time with you to explain the pros and cons of all the possibilities, to tap into expertise that might not even be in your community, it might be somewhere else. If we do all of that, quality goes up, costs go down, care absolutely does not have to be rationed. And the fact is, care is being rationed now all the time. There are all sorts of regulations because we don't have any other way to control costs except to just say no. And so you get told no by your insurance companies all the time. And there are all sorts of sort of inappropriate ways that the lid is being put on care that doesn't really help. We think there needs to be a different approach which actually measures the value of care, that explains that to you and gives you some choice over what you do. Next. So that takes us into where healthcare reform is going in the delivery of healthcare. Accountable care organizations, ACOs. So these are not like HMOs. HMOs were designed to limit care. HMOs were designed to keep you from having care, to put restrictions on your care. ACOs are actually designed to get you the proper care from the proper person, including specialists and imaging and lots of technology, but do it in a more structured way, do it in a more organized way. Get physicians and hospitals and primary care physicians and specialty physicians and nurse practitioners and nutritionists and dietitians and social workers all together to organize care for populations of patients. And that is sweeping the country. And every place you can get a reasonable sized population, 20, 30, 40,000 patients is what it generally takes. You can start to put together these structures, and these discussions are taking place now between us and Renown, for example. Next. PCMH, patient-centered medical home. This is kind of like an ACO only small. This is like in your office, your doctor's office, you have a primary care physician, a nutritionist, a social worker, a nurse practitioner, a nurse, an MA, all structured around your care that then sort of feeds you into a larger system. And there are reimbursement models that go with both of these. So the reimbursement models that go with patient-centered medical home and that go with the ACOs, so that there is no value to the system to do more. The system is supposed to do exactly what it's supposed to do to get the best outcomes. No less, no more. And that's how they get paid, and the same with patient-centered medical homes. Next. Okay, so let's bring this down home. The history of UNSOM, the University of Nevada School of Medicine, has gone through many phases. It started 1970-ish. It was based in Reno, connected to the community physicians, connected to Washoe Med. Small class size, primary care oriented, reached out to rural communities. Did very fine for about 20 years. Las Vegas exploded, politics got very turbulent, the school kind of got split. The clinical teaching mostly takes place in Las Vegas. Now all students go to Las Vegas for much of their third and fourth years. Some students go for the entire third and fourth years. Very disruptive, very complicated politics, north-south politics, which you know better than I. Caused lots of difficulties. Over the last few years, we have started to bring that down to some statewide planning. So there's a statewide committee that was organized by the chancellor of the Nevada System of Higher Education, Dan Klitsch, and through a very intense process that included business leaders like Phil Satry and Michael Nikura, we came to a proposal that went to the governor for 2 schools, full school in Las Vegas, build out the school in Reno, and to layer a lot more residency education on top of that. And that's what's sitting in the legislature right now. We'll see how that plays out. Many of us believe that there is an increasing movement towards that funding, and that UNLV and Ensemble will get its full funding, and we can develop full schools and then put the residency programs on top of that, for which there's funding proposed as well. And we can move forward. So one way or another, I think Reno is going to see a full medical school with a whole new set of affiliations, a whole new set of programs. So let me tell you a bit about the affiliations, a couple stories about the school, and then we'll take questions. Next. Next. So the first big affiliation is with Renown. We signed this last year, approved by the Regents. It's a very broad, comprehensive affiliation. Renown will become the academic medical center for the school. And we will have students teaching in Renown. We'll have more residency teaching at Renown, a host of collaborative programs around neurology, pediatrics. We're in the later stages of recruiting a new chair of pediatrics who will also be the pediatrician in chief for Renown Children's, whose job will be to recruit a whole new set of pediatric subspecialists and expand pediatric care for Northern Nevada in areas we do not now have. So children who used to go to the Bay Area will be able to be cared for here. Next. St. Mary's, we're talking to St. Mary's about a new family medicine residency program to train more family doctors. Next. Northern Nevada Medical Center, we're talking about some collaborative mental health programs that will improve mental health care. Next. This is a huge relationship in Las Vegas. This is Mountain View Hospital, which is a HCA hospital that has engaged with us as their partner to develop a huge new set of residency programs that they will fund completely. This isn't touched by state money. This is completely privately funded by Mountain View, by HCA. We're talking about 250 new residency positions. That will more than double what exists in Las Vegas right now. So that hospital alone is going to do more than currently exists in terms of new programs, new fellowships, specialty training, subspecialty training. Next. Project ECHO is our telehealth project. We provide consultations by specialists to rural physicians and nurse practitioners and PAs and try to teach them how to care for complex problems so they can keep patients in their community. The patients don't have to go back and forth so much. Next. All right, so what does this mean for Reno? Just let me finish with a couple stories about things that are going on. This is why you want a medical school in Reno. So Dr. Tom Brazil, Dr. David O'Coin, basic scientists who are world-renowned for new testing that they've developed over many, many years of research. This is testing for really complex fungal diseases that affect broad populations across the world, frequently fatal. They have some new tests, some new ways to test for these infections that will likely save hundreds of thousands of lives in developing countries. Jim Wilson, a pediatrician we recruited, who is also an international expert on predicting infectious disease epidemics, who does very complex data gathering and analysis to predict influenza epidemics. He was involved in the Ebola crisis. He's proud to say that he beat the CDC in many of his predictions about what was going to happen with influenza and other infectious diseases. The Sanford Center, which is our Center on Aging, the new director, Peter Reed, who's bringing a whole new set of programs to the community, including clinical programs. So on July 1st, we're going to launch a whole new set of clinical programs for the elderly, both wellness programs as well as subspecialty programs in dementia, frailty, mental health care for older adults, something that has not ever existed in Reno before. Student outreach clinic. So medical students in the first and second year take full responsibility for organizing a full clinic every week, at least one clinic every week for uninsured patients. It's a free clinic. The care is totally organized by the students, supervised by volunteer physicians. I'm proud to say that I'm one of those. And we provide care to about 1,000 patients a year, patients who have nowhere else to go, no insurance, nowhere else to go. We provide fabulous care. PA program. So we're in the middle stages of planning a physician assistant program. We'll get site visited next year. Hope to launch the program in 2017 with a whole new population of physician assistants who will be trained in Reno who will come out. And neurology. So we're launching a new neurology residency program in collaboration with renowned specialty nurses before. So after that, I've taken too much time. There's 100 other stories I could tell you. What I want you to know is that there's a lot going on in healthcare nationally that's coming locally, and the school is a major part of this. And we're really going to contribute, I think, to the quality of life, the quality of the business climate. When businesses want to move here, they want to know what kind of academic medical center there is. We're going to be able to show them that and show them partnerships, research partnerships, clinical research that improves care. new training programs, some very high quality stuff. And what it means for you is, I think, better care, more access to care. You'll start to see students in your doctor's office, you'll see residents in the hospital, you're going to be participating in a very engaging, very exciting program. So with that, I hope you pay attention to what's going on in the legislature. I hope that you support us because I think we're bringing great value to the community, and I look forward to working with you as this goes forward. Thank you.
Well, it needs a hard act to follow. Now, before we get into Q&A, I'd be remiss if I didn't mention two people I missed that just joined the men's club. And by the way, about 40% or more are ladies in the men's club. But Joe and Carolyn Cavasso. And with that, we'll open it up to questions. Very knowledgeable, he does an excellent job. Please ask questions. Gary will walk around with the mic or myself. Gary will take that side, I'll take this side.
My question is, after the Affordable Care Act was signed into law, there was a lot of speculation that people would not want to get into the medical field, and that there would be a drop off. But apparently, that isn't happening, which is good news, and it's wonderful to see. How does Reno and Nevada rank with other states in terms of the coordination that you have going on with all these different facilities?
Great question. I get it almost every time. There's a perception by the public that physicians are grumpy and grumbling and whining and complaining, all of which may be true. But the healthcare system is always changing. So when I was an intern, I would sit in the doctor's lounge 40 years ago and listen to the doctors of that era, 1975, complain about Medicare and tell me that I had missed the golden age of medicine, meaning before Medicare. And their definition of the golden age, I think, is when patients pay doctors with chickens, and that there was no insurance, and that the elderly suffered terribly in terms of the lack of medical care. So they would complain about medical care or Medicare. I said, well, I don't know any different, and this is just what I know. And life moves on, and I've had a thoroughly fascinating and wonderful career in medicine. Now we have medical students who say, well, ACA, whatever, doesn't really matter. And we get more applications, and nationally, the number of applications is going up, the quality is going up, the students that we select are better and better, more and more amazing, more and more incredible. Now, buried in your question somewhere, I think, is one issue, which is Nevada does not put as many students into medicine as other states do. We have a lot of work to do in the secondary ed system to pipeline the top students into thinking about medicine as a career. The other part of your question, I think, had to do with sort of coordination across the state. That's a very complicated issue. As a single state medical school at the moment, we work very hard, and I personally am back and forth every week between Reno and Las Vegas to try to stay connected to University Medical Center, the VAs, North and South, Mountain View Hospital, Sunrise Hospital, as well as the hospitals in Reno, to try to stay connected for all of these residency programs, because we have affiliations all over the place. I would say that was pretty fragmented when I first came, and I think it's more organized now, and we actually have more of a statewide view of this and have some coordinating committees and some ways to bring this together. When UNLV comes online, they have their own school of medicine, and they're involved more with some of the Las Vegas relationships, and we're involved more with some of the Reno relationships. It's going to be way better and more collaborative, better coordination, better outreach, more affiliation agreements. I think the state in general is coming to understand that we are so woefully underinvested in this issue and so unsupportive here that the state really has to step up, because right now the state's at the bottom of just about every healthcare measure, so we got some work to do.
Next question.
I'm torn between us being terrible in healthcare providing and why. So I have three kind of questions. In comparison to other countries, what is the R&D numbers? And in those other countries where governments are funding healthcare, what is the tort laws there? And I know that it isn't all tort here, but I know that drives a lot of testing, medicine, and that kind of stuff. So if the government is running the healthcare, are the tort reform like through the roof? And I have another question. In my personal experience, I had a short procedure done a year and a half ago, literally 15 minutes in the OR, and my bill was like $700 to my doctor. I don't know about anesthesia. And then the OR fee from Renown was $3,700, which I'm paying at $100 a month just because it pissed me off that they charged me $1,000. Unbelievable, $3,700 for 15 minutes in the OR. So I'm just curious. My husband's an anesthesiologist, and I said, "What is that about? That you get like $300, $400. My doctor got like $650, and the hospital's taking $3,700, and that's my share. That's not even the provider discount." So I'm just curious, what if you know why the hospital for 15 minutes in the OR?
R&D, charter, hospital costs. All three, in a certain way, revolve around the fundamental issue that in the United States, medicine is viewed as a free market, free enterprise system, and that it's governed by same forces that govern all of the free market, except for one issue, which is someone else is paying some of the bill. And so it allows the hospital or physicians or other healthcare facilities to charge as much as they can to maximize their charges, and then to negotiate from there with different employers, different insurers to pay differing amounts. So there's this, when someone says, how much does this cost? The answer is, I have no idea, because it depends on a whole host of forces that are negotiated between healthcare providers and insurers. So the basic answer to the question about the hospital is, why do they charge that? Because they can't, they get it. The R&D issue is a different slice of this. The US in general puts more into research and development than other countries, but it's done mostly privately for things that make money. So there are lots of potential treatments or other approaches to healthcare delivery that can't really be patented, can't really be controlled, and therefore would have a hard time generating a business plan. And those approaches don't get so much attention because they don't have a monetary value attached to them. In other countries, almost all of which are somewhat more homogeneous in nature, have more government influence over sort of a single payer and across the board system. Patients in general are more compliant, more willing to accept sort of the common good of approaches to healthcare. And amazingly enough, their results are actually better because of this sort of commonality of approaches. But there is less R&D, there is actually less investment in research in most of those countries, but somehow they do better in terms of the outcomes. Final issue is the malpractice issue, and again, we have a very open market legal system that does have some impact. There are widely varying estimates of the effect of that on the cost of care. Some quite high, some relatively low. Personally, I think that there's sort of a combination of legal influence and patient demand and physician desire to help that sort of comes together to cause this more is better phenomenon. And so it's just very clearly known by physicians, partly because of legal issues, but partly because of other issues, that doing more and having a complication is never as bad as doing less and having a complication. If I think that a procedure is not really useful and then something bad happens, I'm going to suffer much more for that legally and otherwise than if I just keep doing things and something bad happens. That's just our mentality, and that's the way we go about things. And so that's a hard culture to break in terms of the cost issues.
Any other questions?
I read in the paper that only 30% of graduates from UNR stay in this state. And after what you said, what you predict in the next few years.
Talk into that mic.
I'll repeat the question. The question concerns graduates staying in the state. How many stay in the state? How many leave? Do they come back? So here's some numbers. This past year, graduating class, only 10% of the graduates are staying in the state to train for their residency programs. Why is that? Partly it's because they're going out of state for specialty programs that we don't have. Anesthesiology is one of those. Radiology, ophthalmology, orthopedic surgery, several fellowships, things we don't do in Nevada because we haven't had the investment by either the state or by hospitals. But our students also leave the state for programs that we actually do have, but they are so good, our students are so phenomenally good that they can match in programs elsewhere that are very prestigious and very elite. And so they sometimes leave. So we've got a lot of work to do in terms of quality as well as quantity and breadth of specialties. Of our graduates who leave the state to train elsewhere, 40% come back. Of the graduates who stay in the state to train, 80% end up staying. So we interpret those numbers to say we need to do a better job of keeping students in the state, but we also have to do a better job of training the pipeline of students to feed into those programs. So the discussion always goes around, should we have another medical school or should we invest in residency education? My opinion is both, because Nevada is behind in all regards. It's behind in number of students, number of residents, specialties, physicians, primary care physicians. We're so far behind that we really have to have sort of all hands on deck. And so I don't think it's an either or issue. That's the way it's been framed, and I respect that, but I really think it's a both and issue, more students and more residencies. But in addition to quantity, we've got a quality issue. We have to invest more. So what does that mean? We have very nice programs. We have good students who go into residencies. We have good clinical teachers. We don't have visiting professors. We don't have the clinical research that residents like to see. We can't support residents as well as we'd like to travel to present the research or to go to outside meetings. There's a lot of the sort of the extra stuff that we just have a hard time supporting on top of sort of the basics. And like I said, our students are so phenomenal. They see fabulous programs. They go off to very prestigious places. We have a hard time competing with that, so we've got some work to do.
Part of the expression, Mr. Ahmed, part of the expression, but you kind of contradict yourself. You're saying you graduate such good doctors that they go elsewhere. Well, isn't it logical that if you're graduating such good physicians, to retain them here with some incentives? For example, your residency program, internal medicine, had some very outstanding Chinese students who scored very high on their exams, and therefore they were given residency here. However, my daughter, who just finished her residency program here, noted that she wanted to start a language program so these Chinese kids could speak better English. It was not supported by the residential the guys who ran the program. So these type of things like communication, which to me is the most important of anything in medicine, was not being promoted by the program. So these kind of things don't cost much. So what are you going to increase those and retaining the students to stay here?
Well, I'll certainly look into that, but everything you described does cost money. I don't think people realize that we are in such a bare bones budget compared to a typical medical school and a typical residency program. We do not have the kind of support that the top programs have. So even things like language programs are difficult sometimes. But I think the bigger issue is that we work very hard to recruit our own students. We do everything we do students. I'd love to have even more ideas for how to do that. We rank students according to what we believe to be their quality, and it's their choice. So we do the very best we can to rank the very best students, and whether they come to us or not is to some extent up to them.
I have a question, and then we'll just take a short break because he does such an outstanding job. We want to do the 50-50 to see who won. And,
Thank you. Just quickly, it's a bit confusing when you say that you don't have a budget to help Chinese students speak English. Why would you support both policies of increased residencies and another medical school in the South when there's so limited amount of money that can't come from the legislature, as well as such a limited amount of money that you have available already?
Well, if I was forced to choose, I would take the residency programs. I just don't want to choose. We need both. And yes, residency programs would be a more immediate next step, and we could invest in those, and that would be good. We're still so far behind, and that's not going to solve a lot of the issues that I talked about. But yeah, if I'm forced to choose, you're right. I think I would start with residency programs, but I think that's a false choice. I guess I'll put it that way.
I know I have a question, but I'm gonna wait till we do the drawing. And please stay, even though if you have to leave at 1, we understand it's right at 1 o'clock. Carolyn, could you have maybe the doctor, the drawing?
That's exactly what I was planning on doing. Thank you, Penny. Get your tickets out, because we're giving away money. Just one. We're very generous at the Republican Men's Club. Okay, the winner is 1847406. Oh, she wins every time. We collected $96, and we're going to give Georgette $48. Oh, she just donated it to the honor flight. Thank you so much. Just a reminder, I have honor flight tickets and golf event information. Thank you.
By the way, Georgette donated, she won the last time, and she donated. Very generous, so this is for the honor flight. And now ask question, Doctor? Huh? I was gonna,
Hey, real fast, we have 2 cards. We normally have early, first person who pays, who signs up each month. It's a $10 Starbucks card, James Smalley. Yeah, thank you for signing up early. And the random pick of people who signed up was Dr. Pick number 12, so it is Kathleen Doyle.
now I want to let you ask a question, but he has to leave very shortly, so we need to have short. Who had a question? Go ahead, Gene.
First question is, do you support tort reform? And second question is, clearly from your graph, you show that when people reach about the age of 60, they use a lot of medical care, but not in relationship to the other countries. What would you do if you could fix that, if you saw that?
That's a great question. Yes, I definitely support tort reform, but it's not just about the legal system. It's about our whole culture and our belief system that says that we just want things done to us, and we don't, as patients, get good explanations for what the consequences of those things are. The implication is that how could we not want more things done? What could be bad about that? And those of us in medicine know all kinds of things that are bad about that. And in fact, there are lots of studies done that look at how physicians make decisions about their medical care, especially as they get older, and especially toward the end of life. And they make decisions about their own medical care drastically differently than what most patients do. And I think that's because we know the implications of this technology. We know the complications. We know the false positives that come from tests that lead to other tests, that lead to other tests, that eventually leads to a problem. And we don't want that for ourselves. So the question would be, how can we change that for the system? And I think the answer to that is much more time and effort devoted to explanations for those tests. We have incredibly powerful and potentially incredibly dangerous things that we do. And we don't talk 30 seconds about those. We just write stuff down and give you a piece of paper and away you go. And we don't have a clue as to what the implication of that decision was. That's what we have to focus on. I think if we fed that into tort reform, the two would come together and we would have much better care. You would much better understand the pros and cons of what you're choosing. And I guess the final thing I'll say personally is I have had experiences with patients who had very good and well-formed views about end-of-life care in particular. And they got swept into the system, and the system just sort of took over, and lots of things happened that were not consistent with their beliefs and with their decision-making, and it left huge anger and upset amongst their family members that to some extent comes back to the physicians. And I'm very sensitive to that issue of trying to do better and helping people make the decisions about their care. There's plenty of money, plenty of care to go around as long as we make the right decisions about it. But tort reform, to get back to your question, definitely feeds into that. I would personally favor more of a required sort of arbitration system and just say, mistakes happen, admit the mistakes, have some sort of compensation, and avoid a lot of the legal expense that goes with that. But there are probably trial attorneys here who will
Doctor, I think Doctor has done an excellent job. Please give him a round of applause. Thank you for coming. Our next meeting is a dinner meeting. It's the third, every time is the third month of each quarter is a dinner. And it's on the 16th, doors open here at Atlantis at 5:30. And we're going to have Mr. Gallo that's going to speak on financial issues, how they affect your pocketbook. Again, thank you, Dr. Schwenk. You can stay, socialize, whatever, help us tear down. We'd appreciate it.
So if you can share like share screen like that, and you pick a screen.
Do this again next month.
Okay, thanks. You know, actually, there's another person who has $10.
I don't even drink Starbucks, so.
You like wine?
Huh?
You like wine?
Oh, I love wine.
We'll give you a bottle of wine next month.
Okay.
We don't usually give wine, we just Starbucks. Screen share. You know, hopefully the screen share.
Yeah, no.
Screen share is right here, then you go to the screen. Fire screen. And you pick your screen. I rub it on like why can't I minimize it? It's so weird. I do this all the time. I remember I said this on this window, that might be a problem. If I go to launch it on this one, I think it would be I'm sure we got it. It's just I can't do screen share on this. So if I want to kind of like this, I still this on a separate I just do screen share content. See, that's the whole problem. I'm always off the right.